All right. Good evening, everyone. Thanks so much for joining us. You are seeing double because the other screen is actually our marketer who controls all of the Zoom technology on the background. I'm going to ask that everybody mute themselves, and with questions, please use the chat box or take yourself off mute and then jump in and ask questions. We have about another 10 people that have signed up or so, maybe even more, that will probably be jumping on here as we get going, because it's just a minute after 6. So, but we will continue on and kind of go forward. I'm excited about tonight. This is going to be really fun, but certainly if you have questions as we go, please let me know. Yeah, please let me know. So if everybody can mute themselves, that'd be great. And then we can just kind of jump in. All right, very good. So I'm Michelle Moser, and I own Maker's Compounding Pharmacy. And tonight we're going to talk about the medication low-dose naltrexone. And we're going to talk about kind of the basics behind LDN, how it's prescribed, how the medication is used, and for what issues, specifically what diagnoses. What I love about low-dose naltrexone is that there is so much information about it. And I think that is the one biggest piece that I learned very early on. So I started learning about low-dose naltrexone about, well, let's see, this is 22. So it's probably been 7-8 years. It's actually been FDA approved since 1964. It was just a larger molecule. And what I mean by that, it's commercially available in a 50 and a 100 milligram tablet. But it was designed because in the early 60s, the FDA was commissioned to basically prove how medications worked that had already been on the shelves for many, many, many years. And so there were a couple of actions taken on by the FDA that actually turned into bills and laws that needed to prove that medications were safe and effective. And so in order to do that, a lot of times we had to build medications to kind of counteract what was already there. And that's how naltrexone was originally developed, because we knew that morphine worked, but we had to prove it. And we had to also prove its kind of upper limits, lower limits, and its safety and effectiveness and all of that good stuff. So naltrexone was actually developed to be kind of an anti-morphine. And through that, we actually learned so much more. But it wasn't until 1985 when Dr. Bahari was prescribing naltrexone to a group of his patients. So he was deep in the AIDS scene. So he was a triple board certified educator, physician, who realized that a wide variety of AIDS patients also had other comorbidities, specifically alcohol overuse syndrome, and others had drug issues and things like that. So he was actually using naltrexone to help them get off their alcohol, to then try to help their overall immune status. As we all know, alcohol is an immune suppressant. So if you could take that addiction away, then we could help build everything back up. Well, what was also going on is that the majority of his patients were male, is that they weren't working. And so they had to, and back in 85, we didn't really have a lot of, direct insurance payments with the pharmacies, right? You paid for your medication, then you filled out your form and you sent it in and you got your money back, kind of thing. Well, these patients, these gentlemen, didn't have a lot of money. So what they did is they started breaking up their tablets to try to extend them. So extend how much they actually had. And he literally had an epiphany in the middle of the night. He actually reported that it was like a 1 o'clock in the morning kind of thing, where he woke up and realized that the reason behind his patients getting better and that their T cell counts were going up is because Naltrexone used in very small doses was actually an immune modulator. It was super cool. So then he went on to say, okay, so how does this actually work? And what do we actually do with it? So he literally took a group of patients. It wasn't very big, but he took a group of patients and then he continued to decrease the dose quite a bit. So in 1985, 86, 87, thereabouts, we had, pharmacy's been compounding since day one. That's where it all started, right? Toothpaste was actually originally made in a pharmacy, but almost all medications that we see today originated as ideas, at least in a compounding pharmacy. And a lot of them actually started as combination products in a compounding pharmacy. So he literally went to a compounding pharmacy and said, hey, what can you do? And with that, he was able to enhance the quality of life, and in some situations actually extend life for those individuals who were immunocompromised, diagnosed with AIDS and HIV. And this was pretty cool. That original bit of research has been built on. And then in 1996, it was a mechanism of action for low-dose naltrexone was recognized as a very different mechanism of action as what we saw in typical dosing of naltrexone. And then Dr. Ian Zagon has then taken that information, that original research, and just run with it. And today, so at this point, he actually published over 300 papers on low-dose naltrexone. But today we have well over 900 published articles, case studies, research on low-dose naltrexone. So when some providers call and they say, what is this used for? How could this possibly be? Or no, I'm not going to write the prescription because we don't know anything about it. But we do. We have a ton of research on it. So what was found is that disease is an expression of a malfunctioning immune system. That's what we typically know. Because the immune system is regulated by endorphins, which have a primary action on opiate receptors. So not just those that cause pain, but also the opiate growth factor receptor, which not only controls tumorigenesis and a wide variety of tumor growth. But what we also know is that by upregulating endorphin production, so if you block the endorphin receptors, the body's going to make more endorphins. That's how you can also positively modulate the immune system. So we're not boosting the immune system, right? We're not actually taking it from a low level to a high level. That's not what's going on. We're actually modulating this. And what we also know is that there is a subtype of endorphins that can actually suppress other types of cell proliferation. So we are working in multiple arenas at the same time. What we also know is that toll-like receptors are definitely bombarded or encountered with LDN. We know that macrophages, microglia cells, interleukin cells, different kinds of cytokine productions are also changed by low-dose naltrexone, including tissue necrosis factor, which is super cool. Now, when we deal with toll-like receptors, we're primarily talking about toll-like receptor 4. However, toll-like receptor 4 is primarily in the macrophages, monocytes, natural killer cells, mast cells, dendritic cells, and microglia. And microglia is made up of, what do they say, somewhere between 70 and 85% of the gray matter in the brain. But we also see toll-like receptors, toll-like receptor 4 and 9 specifically in epithelium, whether that's internally or systemically on the outer skin, but also on fibroblasts in the skin itself. So we also know that LDN will actually transition TH1 to TH2. So we can actually get away from kind of an allergic response to a more normalized response. Because TLR receptors are found both on the outside of the cell, but also on the inside of the cell, that's where, again, when you're dealing with cell basic function, we can actually use this medication for a wide variety of application. The Dartmouth study is the study that summarized the first 900 articles. And so the individuals at Dartmouth back in August of 2018, so that's been 4 years now, took the first 900 articles, basically summarized those and categorized by disease state. So it will literally have a section on a very specific disease state, and then those articles that are associated with that disease state, it summarizes where the article was produced, what type of production was it? Was it a crossover double blind, or was it just simple case study? Exactly how many participants, the dosing strategy and dosing schedule, and then the generalized summary of that study as well. And if you need a copy of that, let us know. We can send that electronically or send a paper copy, whatever you prefer. But this is literally one of my favorites. But what we also know is that since 2018, and literally in the last 2-3 years, there have been approximately 50 more articles written. So this medication is extremely well studied. It may not be traditional mainstream, but there are studies going on in both Chicago and New York that are looking at LDN and long haulers COVID. We are looking at LDN and chronic regional pain syndrome. And there's another group that is studying LDN and Crohn's. Now, the CRPS and the Crohn's group is actually studying LDN to then release it into the commercial manufactured stage. But what I find, and so I became a certified LDN master specialist about a year ago. And what we have found over the last few years is that Bahari's initial schedule and Dr. Zygon's initial schedule of dosing, which was 1.5 milligram for 1 to 2 weeks, 3 milligram for a couple of weeks, and then go up to 4.5. That works about maybe 50% of the time. And the reason is because when you have so much inflammation due to a wide variety of disease state, and let's face it, isn't all disease actually centered around inflammation? I mean, it really doesn't matter what we're talking about: arthritis, hypertension, diabetes. I mean, it's all centered around inflammation. And anytime we can reduce that inflammation, that's where we're going to see better outcomes. However, when somebody is very inflamed, they become incredibly sensitive. Everything is kind of on overdrive and things are working really quickly and much, much too quickly. And in doing that, patients tend to be incredibly sensitive with their medications. So if we can help through compounding how to actually get to that person's individual happy dose, that's where that person is going to feel much better. They're going to be able to be more productive in their private life, but also in their work life, and then live a much healthier overall life. And that's the key. I think that's why any of us who are literally scientists at heart, who got into medicine to begin with, that's what we've all strived for, is just to take care of patients. And then when the patients literally come back and say, this has changed my life, there is absolutely nothing better as a pharmacist. There's nothing better. But I will share with you, one of my very good friends was a naturopath up in Bellingham, and she practiced for, 40 years before she retired. And she retired, and she has been, over the last few years, selling her clinic. And she popped into the store a few months ago, and I was in my office, and she asked if Michelle was available. And I always, kind of listen, see who that is. I recognized the voice, but I was having a hard time putting a name to it. So I listened a little bit more, and I peeked my head around the corner, and I walked up to her, and she says, "Hi." I haven't seen you for a couple of years. And I'm going, oh my gosh, I know this person. I know this voice. Who is it? But just like everybody else, my hair changed over COVID. So did hers. She used to have very long hair. Her body structure was still the same. She was still, the same height. She's a little tiny person, but she cut her hair and it wasn't so much kind of a sandy brownish blonde anymore. It was gray, just like mine. So she said her name and she asked if she and I could speak, kind of off to the side. And she literally said, "You saved my life. You literally saved my life and my marriage." And I just listened. I mean, that stopped me right in my tracks. And she says, 4 years ago, I took one of your classes on low dose naltrexone that was sponsored by the Naturopath Society, the naturopath organization. And she says, I took it because I needed the credit, but also you were presenting and we're good friends. So I wanted to take your class. I said, great. And she says, now I called you Monday morning and do you remember what you said? And I said, yeah, I know. I remember exactly what I said. I said, this is low dose. It's low risk, low side effect. It's low cost. So why not give it a shot? And she says, and that's what I did. And then she says, you helped me guide me in my dosing so that we found her happy dose, which I believe is like 3.25 milligrams. I mean, that's not that's kind of in between everything else. So what we were able to really take care of her issues. And she has significant Lyme disease. But her Lyme also then caused a wide variety of other issues as well. And with low dose naltrexone, she has had much better quality of life. And she literally said when she forgets to take it, she understands what's going on and it doesn't help. With low dose naltrexone, literally, the reason why this is just a very, very, very small list of conditions that we use low dose naltrexone for. And these seem to be kind of all over the board. But all of these situations have the center of inflammation or an immune modulatory issue. And when this medication works on both of those pathways, we see much better results. We also know that if someone is using low dose naltrexone and for whatever reason they need to stop, let's say they're going to have a planned surgery or an emergent surgery, then we literally would stop LDN for 3 days before that, if possible. But because it has such a short half-life, that even if somebody was, in a horrible car accident, they broke their leg in 10 places, they had to go to surgery. If they took their LDN last night, the most of the medications used in surgery and the pain medications would still work. But we also have so many other medications that are not opiate based that we still have ways to actually control that pain and allow for that surgical procedure to happen and that person to be better. So LDN literally could change people's lives. The editor of the LDN book, which there's LDN Volume 1, LDN Book Volume 2, Volume 3 will be out in November. There are different chapters written by physicians, therapists, clinicians, nurse practitioners, people from a variety of background who give not only the science behind LDN, but very specific case study as well as dosing. And what I appreciate about all three of those books is that they don't say, you must use LDN for blah, 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 because it's not a sales pitch, right? It's not you don't feel like you're being greased over by a used car salesperson at all. You're literally reading the scientific information that these providers have used in their own practices, gathered up, and then succinctly put into a chapter. And literally between the three books, there are very few crossover or duplications. There might be an extension of like Hashimoto thyroiditis or an extension of a viral infection. But literally the first chapter, which goes over the true mechanism of action, and that's written by Stephen Dixon, who's a compounding pharmacist in Scotland. That's the only chapter that repeats the same in all 3 books. And we go over so many different disease states where this drug actually has a dramatic impact. Some of this is available on YouTube. You can literally listen to Dr. Phil Boyle. He talks about infertility. You can go out to the LDN researchtrust.org. You can look at their website. I believe the previous conferences are available free of charge. I will warn you, they're like 2.5 days long. So it's a good 20, 22, sometimes 32 hours of information. There is an on-demand conference that starts with the LDN Research Trust. Next in a week or so, I think a week from Saturday on October 1st. And that's on demand. And with that, you literally get to study at your own leisure. There's CE available as well. And you can also study to be an LDN master specialist if you wish, if you really want to take it that far. It's actually kind of cool. And then the information that we can actually use and then take home and put in practice Monday morning is just phenomenal. So again, to kind of go back over this, how can one drug really do all of this? And again, because we are dealing with the very basic cellular responses, and because most disease is actually founded in that, it works very well. So even if we have a topical autoimmune issue like lichen planus, lichen sclerosis, eczema, psoriasis, things like that, we would still use an oral dosage form. And then we can also use topical as well, because sometimes those disease states that are formed in the skin or are founded in the skin have a lot of itching. And because we can move Th1 to Th2 and decrease the itching response, then a topical preparation can be used in addition to oral, but you're not going to get at the root issue by just using a topical. So first pass through the liver, only about 5 to 40% of the body of the dose actually enters the body systemically unchanged. We do use a lot of sublingual dosage forms as well. And we know that with a transdermal, so that is actually pushing all the way through the skin to the central blood supply, there is a lag time for efficacy or onset of action. We use transdermal doses, especially in those who cannot swallow. So autism and kids that are on the spectrum. Dr. Brian Udell out of Florida has been using low-dose naltrexone since Dr. McCandless started studying this back in the 90s, and he's got great success with that. But most of those kids that are on the spectrum, they're not oral, right? You can't go anywhere near that. You've got to even be careful with color. So we're very careful about how we actually formulate that transdermal gel in the device that we put it in, because of the color aversions that sometimes the kids have. And then usually we're putting that in a Topical, so the caregiver, mom or dad, can literally just twist the bottom of it. The dose comes squiggling out the top, and then it can be applied usually to the inner wrist or the back of the hand, very vascular areas, very thin skin areas, so that it can then be absorbed throughout the body. And it will miss first go round, so it'll actually hit target tissues first. In children, we usually use a little bit higher doses in kids because kids metabolize so much faster than adults. So with adults, we usually use either oral suspensions, whether those are water-based or oil-based. We have troches and we have capsules. Now, we do know that low-dose naltrexone is available commercially combined with bupropion, and it's called Contrave. So we use that for weight loss. So it is commercially available. It's just combined with other medications. And because it's already at an 8 milligram tablet and it is longer acting, we wouldn't necessarily use that medication for someone who has depression. Because what we find is that in order to ensure that we have an upregulation of endorphin production, we need to intermittently introduce the medication. which means it's usually once a day, maybe twice a day, but usually once a day, preferably at bedtime, so that as the body is calm, we can actually see endorphin production over the next 18 to 24 hours. Now, if the main side effect that we see is vivid dreams. Well, vivid dreams is how we know the body's actually working in the body, because it drops you into REM sleep. So, but a lot of people, those vivid dreams are scary. They literally will disrupt sleep. And that's not the point of using this medication. But we also use it for PTSD, depression, things like that. So if that's the case, then we'll move the dose to the morning time and allow them to kind of move along with their titration. So this is some case studies, some journal article excerpts about how low-dose naltrexone actually works with autoimmune. And we've seen a lot of talk about interleukin 6 and 12 over the last 2.5 years because of COVID. When COVID enters the lung, we do see a lot of interleukin 6 production, which increases inflammation. That also allows fluid to then swarm the alveoli and basically, get trapped in there because of a lot of the inflammation, but also because there's just so much fluid, and then it doesn't leave. So when we are able to literally block cytokine production because of that, then we're able to see where it can work very, very well. There are studies that have gone on with Alzheimer's, ALS. Some of these are postmortem, but a lot of these are followed with those individuals through their disease. Now, the editor of the LDN book, back in, let me get my dates right here, late 1990s, she was an early 40-something lady who was married with children, and she was literally bedridden. She had no quality of life. She could not do anything for herself. She has multiple sclerosis. And when you listen to her story, it's very poignant. And she, even to this day, she gets very caught up in her emotions. But when she found low-dose naltrexone and she was able to convince her physician to write that prescription, today she runs the research trust, and it has literally saved her life. She was able to get out of bed and start taking care of herself and taking care of her family, even just after a few years. So it does take a little bit of time so that we can see progress, but it's not going to happen immediately. Some people actually see some results and increased energy in that, but we need to give it usually about 4 to 6 months before we pull the plug. But we also see upwards of sometimes 9 or 10 dosage changes within that period of time. So autoimmune disease a lot of times is centered in the gut. If the gut dysbiosis is such, it can actually allow for metabolic material to leave the gut and literally go through the bloodstream and land in other target tissues that we don't like it to target, but that's how we can enhance autoimmune issues, is by the quality of biosis in the biome in the gut. But these are just a few of the autoimmune diseases and the actual main organs that are associated with that. Also, let's see, not necessarily, skin, here we go. So psoriasis, vitiligo, eczema, and scleroderma are probably the 4 biggest. And I'm going to see if I actually have a couple of slides here in the skin section as we move forward. So neuroinflammation, it's probably the leading cause of dementia, and Alzheimer's probably has a huge contributory factor to even Parkinson's. So because we know that there are inflammatory mediators that are pro-inflammatory, can actually change and increase a wide variety of pro-inflammatory chemicals. And we know that low-dose naltrexone works opposite of that, we see that inflammation in the brain and the microglial activation is lessened with low-dose naltrexone. Yeah, boy. There's so many women who come in and they're concerned that things are really going awry or really amok in their brains, because they just can't remember things and they just can't seem to feel normal. And maybe that's a hormone issue as well, but we also know that low-dose naltrexone has a real positive effect on helping normalize estrogen, progesterone, testosterone, DHEA, pregnenolone production. And anytime that we can slow down dementia, slow down cognitive issues, everybody's going to be happier and healthier. We also know that there is a very distinct component of what is actually happening with your blood glucose, and then what happens with memory decline and dementia, even amyloid plaque production that leads to Alzheimer's. And I'm going to go back real quick. So with that, this study is a really interesting study. There's another one out of Tokyo that specifically looked at what is happening in the brain with neuroinflammation and how not just low-dose naltrexone, but even estrogen plays a huge role, both in men and women to a greater degree because our brains are bathed in estrogen. I think that's why we were able to multitask a little bit differently than guys. It's very interesting, the research that's been done. So we know that low-dose naltrexone also can affect a wide variety of cancers. It can actually slow tumor growth, and actually on MRI and a wide variety of PET scans, we have articles that show this, where we have a baseline and then we have low-dose naltrexone and what is happening at the 90-day mark and at the 6-month mark, even a year later. And a lot of times these tumors are gone, and literally the only thing that's changed is low-dose naltrexone introduction. So it's not like there is a couple of studies where people are on traditional chemotherapy and they're actually able to use just a fraction of that typical dose. So therefore a lot less side effect and a lot less degradation of tissues and the body itself. But yet when we use low-dose naltrexone, we can reverse some of those issues, whether they're neuropathies or hair loss or a wide variety of inflammatory response. So Dr. Zygon, like I said, took a lot of information that Dr. Bahari started with and just went with it. He rolled for a very long time in produced so many different studies in a wide variety of areas. He didn't focus just on cancer. He actually looked at deeper dive into the mechanism of action, and then looked to see how it would affect different disease states. And there's the OGF. These two studies specifically looked at, the why and the where and the how. And this is the information that we came up with. So, it's really cool to go back and read this. So if you look, 2 of these studies were done in 2006 and another one was done in 2018. So this is pretty new stuff. So again, low-dose naltrexone is not expensive. 90-day supply of our 4.5 milligram capsules, it runs less than $80 for a 3-month supply of capsule. That's pretty dang good. So like I said, with chronic regional pain syndrome, there is some very specific study that's being done right now on a dosing regimen to help change the outcome of CRPS. So CRPS is usually due to a significant injury, a dramatic trauma, whether it's to in the periphery, like an ankle or a wrist, and literally things are bent the wrong direction for quite some time. And one thing that they are starting to note, they're going to do a little bit more research on this, is that, of course, the sooner you start LDN after the injury, the better outcome that you have. However, even those individuals who have been dealing with a long-term chronic regional pain syndrome still find benefit. And many people are walking again, are using their limbs the way that they originally did. So they still might need some assistance with a cane, but usually they're finding that that is significantly reduced. Same thing with neuropathy. Now, anytime we're dealing with a chronic pain issue, what we usually do is we start with a very low dose, maybe even a 0.1 milligram, and slowly increase that. Now, we don't ever want to use a long-acting product, because that's not going to intermittently block the endorphin receptors. We're not going to see an upregulation of endorphins. We want to make sure that we see this intermittently so that we can continue that endorphin production. But we have noticed that some people need a little tiny dose, let's say in the morning, and a little bit different dose in the evening. So if you do have somebody with arthritis or a neuropathy or a chronic pain issue, sometimes a twice-a-day dosing is helpful. So usually what we do is we start with a low dose and we slowly increase that. And then when we get to be about 2-3 milligrams at the bedtime, then we'll add a tiny dose in the morning and slowly increase that, so that they might be on a total daily dose somewhere around 5 or 6 milligrams, but those doses aren't necessarily equal. So they may be staggered, or the morning dose might be higher than the bedtime dose. And that's okay, because with this medication, what we've also found is less is more. In some situations like fibromyalgia, there's always a chronic pain component to FM. And with that, we sometimes don't see great response within even 4 months. And really, when somebody's dealing with chronic pain for many, many, many years, decades even, we want to really help them tackle their issues. So we start slowly increasing that dose, but we tell them, look, if you've given it 4 to 6 months and you have not seen significant changes, we're going to stop LDN. And then after about a month, we're going to start lower and slowly increase again. And what's interesting is that we capture about another 30% of patients being successful. And I think it's because the body then recognizes what's going on, and then we have better endorphin production. And I think it centers around having to reduce inflammation significantly before we can actually see a change in symptom list. So is topical LDN better? Oh, for arthritis? No, it's not. And the reason is because you don't get the same response. You don't get the same absorption with topical LDN, or even in an adult with transdermal LDN. So topical literally stays in the first few layers of the skin. It doesn't necessarily go past the stratum corneum, which separates the epidermis from the dermis. Transdermal will push it all the way through, but again, this is affecting cellular level inflammatory response, not just necessarily in the skin. So the reason why you feel it in your joints is because usually that's where the pro-inflammatory chemicals kind of settle out. So we want to make sure that we are attacking it from the inside out, so to speak. You're welcome. Oh. So Dr. Chopra, oh, I think I skipped a slide here. Oh, no, I didn't. We went over that a little bit. Oh, this also kind of brings up another thing that a lot of times when people have chronic pain, they're on a variety of medications already. And many of them are very motivated to get off of their opiates and off of their benzodiazepines, off of their muscle spasm medications, things like that. And we can actually kind of tackle both at the same time. So we can use naltrexone in ultra low doses, literally 1, 2, 3 micrograms. And that's based on the oxytrol study that was done at Stanford or Yale. And that was a combination of oxycodone with a little tiny bit, literally 1 to 2 micrograms of naltrexone. And we were able to decrease the opiate dose and increase the ultra low dose naltrexone. And literally they got just as great a pain control. And then we were able to drop the opiates altogether and then increase their LDN up to a typical LDN dosing, which is anywhere from 0.5 to 4.5. And then they're off their opiates. But many of them are also on benzodiazepines and other medications for muscle spasms. And we can do the same thing. So it doesn't hit the same, LDN doesn't hit the same receptors as the benzodiazepines, but we can often see where we can reduce those dependencies and increase quality of life. Because we also know that narcotics, synthetic or otherwise, as well as NSAIDs and benzodiazepines, actually deplete their body of very important vitamins and nutrients that help control pain. So if you decrease that, you're going to be in more pain just because you don't have those other entities. And if you need any of the studies that are noted here, let me know. Dr. Chopra was very kind. He's a professor at Brown Medical School back in Rhode Island, and he put together a huge talk in 2016 at the conference. And I believe you can listen to this on the ldnresearchtrust.org. I believe it's free of charge. And he's a phenomenal individual. He's so caring. He just wants to share the science so that other people can benefit from what he has found over the last, I think he's been using low dose naltrexone for about 10 years. Very successfully for a wide variety of issues. When we're dealing with dermatology, these are probably, with the exception, I mean, scleroderma is not on here. That is probably the 9th most popular reason why we use low dose naltrexone. So it hits not only the TLR4 receptors, but the TLR9. TLR9 is on a different part of the cell, and we can use low dose naltrexone by itself or in combination with other medications to help with these disease states. So Hailey-Hailey is an autoimmune issue that dramatically impacts the everyday life of these individuals, men and women. A lot of times they aren't able to put clothing on just because they are so inflamed and in such pain. But even with psoriasis, that's a very unsightly disease for a lot of people. It's red, it's raised, it's got a huge plaque associated with it. And a lot of times it's in areas that either bend or poke out. And we can use low dose naltrexone orally to help go at the root, but you can use it topically to also help reduce the inflammation and the itching. But we can also combine it with other medications like zinc, like cyanocobalamin, to help rebuild the turgor of the skin, to really go after what's happening with the fibroblasts and then the fibrin production, as well as the collagen production. When we're dealing with pruritus or even eczema, we can add a little bit of ketotifen, really help with that mast cell integration and decrease that very quickly. With alopecia, it depends on really what diagnosis and what type of alopecia they're being diagnosed with. So there is a test, it's a cheek swab, and it's called Trichotest, Trichotest. It is a real quick cheek swab, runs about $300, and it's a once in a lifetime kind of thing. But what it does is it identifies where in the hair production process there's deficiencies. So then we can target exactly what kind of medications do we need to use to then reduce that to help the hair actually regrow. Now, if somebody has alopecia universalis, and they've had it for 10 plus years. I don't know if somebody's going to be walking around with a full head of hair in a year, right? I mean, that's a little bit more difficult. But when we have seen alopecia at the earlier stages or with a different diagnosis, we can see hair regrowth. It does take time because it takes about 90 days just to form that new hair for it to pop out anyway. So we do need to give it a little bit of time. And those are the expectations that we set up with our patients as a dispensing pharmacist, to make sure that from the very early onset that we understand what the outcomes are going to be and when to expect results. Because if we don't set that up originally, we don't want people to say, it didn't work. I gave it a month and it didn't work. Well, you're right, because you only gave it a month. And really, they've been dealing with these issues for years, if not decades. Please give us just a little bit of time. And I actually have pictures on everything from a wide variety of hair loss situations to vitiligo, even psoriasis and eczema. And the most poignant picture that I saw was a young single mom who had 2 little boys, and she worked in an office, and her eczema was so significant that, she had these cracks and they would bleed, and you could literally look like she could just peel the skin off of the palmar surface of her hands. And so she was forced to kind of walk around like this so that, her hands wouldn't crack and bleed. So she couldn't really type very well. It really significantly impacted her everyday life, let alone helping her kids get ready for school, get ready for bed, get in and out of the bathtub, even cooking, things like that. And literally within 60 days of being on LDN, her hands look really great, just phenomenal. And she continues on LDN to this day because she found that when she went off of LDN, things kind of came back. And really, it's because LDN doesn't cure anything. It tricks the body into working on its natural processes normally within its own parameters. So when you stop LDN, the benefits of LDN stop. So pretty much a summary of what we talked about on this. And this is Dr. Lee's published article. And this goes over a wide variety of dermatology conditions. And this was an article, it's not even 4 years old. So what we found is that, especially in dermatology, it's been found to be very safe and effective. It's in low dose, low side effect, low drug interaction, low cost. Pretty easy to handle. When we notice that we're using higher doses, 50 to 100 milligrams, you still can use that for itching, but we also see liver impairment. So we do see changes in LFTs, so we have to monitor that. But even in low dose, we see better benefits. So we just stay within the lower dose guidelines. And I think I have pictures of, I think we'll get there, some of the forms that we use to help with guiding and keeping people on track with their dosing. Crohn's disease, ulcerative colitis, irritable bowel. Again, these are, this is Dr. Jill Smith's work going back to 2007. She is one of the primary physicians that is looking at Crohn's disease and using low-dose naltrexone to actually patent that and then have it available commercially. And I think that that's wonderful. I think that that's great. But I also know that, especially with Crohn's and UC, that sometimes the typical 1.53, 4.5 milligram dosing parameters or schedule doesn't necessarily help. There are some people that need to be in between those because it will block the opiate receptors in the gut, so it can slow the gut down a little bit, which for some people with ulcerative colitis and IBD, that's great, right? I mean, that's phenomenal. And in the first LDN book, Dr. Leonard Weinstock, who's a gastroenterologist in Missouri, I believe, showed pictures, colonoscopy pictures and upper GI pictures of baseline and then 4 months after starting of LDN. And so baseline, the inner lining of the bowel is very red. It's very inflamed. It looks like if you touched it, it would start bleeding. It's really mucousy. I mean, you literally saw white yuck in there. And then 4 months later on LDN, I believe his patients were taking 4.5 milligram. The inflammation is reduced. It's pink, but it's really kind of a typical skin, and there's absolutely no mucus whatsoever. Why not? And I will say Dr. Weinstock also talks to his patients about the issues behind gluten and making sure that they're taking good multivitamin and B complex omegas, things like that, so that, and zinc, because we need to repair the gut. And then he also talks to him about putting the good bacteria back so that he can help correct the dysbiosis. Depression. So especially for those providers that are on the call, what patient hasn't come in talking about how crappy they feel, right? And some of them have tried SSRIs or SNRIs, and they are kind of helpful, kind of not. There are some gut tests that we can actually look to see if somebody is producing the right types of good bacteria. Does the gut actually produce serotonin and GABA so they can feel good about themselves? But we can use low-dose naltrexone to, again, incorporate the release of endorphins and enkephalins and, decrease the symptoms of depression. That is really important, especially when you already have a significant diagnosis like bipolar, schizophrenia, anorexia, OCD, and autism. And so we again start using small doses and slowly increase. We tend to use liquids more often in this situation so that we can very carefully manipulate that dose just by increasing the volume. So we just give them a concentrated bottle and we show them, how if you increase that dose, that can help. Now, what Dr. Forster and Dr. Lannis have both talked about during the LDN Research Trust conferences, specifically in 2019 and 2017, is that with depression, and especially medication-resistant depression, they often will use LDN in 2 or 3 times a day dosing. They follow very, very carefully. And they're literally checking in with their patients probably every 5 to 7 days. And they really watch for anxiety because of how it will change the opiate receptors and how it binds to that. And also how we see the release of endorphins. Sometimes people get wound up with that, and that's where it triggers anxiety. So they're very careful about B vitamins. They actually check for a methylation SNP, because if you're not methylating, that also can increase anxiety. So they work with a lot of other parameters, a lot of other subsets of diagnoses to ensure that they have very good outcomes. But these people are very closely monitored, and they're not left on 3 times a day or even twice a day dosing for an indefinite period of time. It's usually just a few months, and then they're slowly tapered back. And that's, again, because we don't want to bombard the body with LDN on a regular basis, because you will literally stop the upregulation of endorphins. And when we're dealing with depression, that is the primary area of psychiatry that we really want to see LDN work. but depression has a huge inflammatory component as well. This is Dr. McCandless, her study in 2006. It was a short study, only 8 weeks. There were 15 patients, and they were between the ages of, I think it's actually in here, I forget. I want to say as young as 2, all the way up to, I think, 12. Most of these patients were not able to swallow, so this was a transdermal application, and this is where she discovered that there's a delay in onset. So that's why when LDN was given between 9 p.m. and midnight, there were some changes in the brain waves that actually cause endorphin elevation to stay throughout the next 18 hours. She also used liquids to begin with, but LDN is really bitter. And back in 2006, we didn't know as much about flavoring as we do now. So right now we will make low-dose naltrexone in oral suspensions that are usually oil-based. And we do that because we can give it a long beyond use state, so up to 6 months. But there's so many wonderful oil-based flavors. So we have one that's a berry cobbler. We have another one that is peanut butter and jelly, and really fun flavors. So not just your typical mint, because a kid is not going to take anything mint. They hate even mint toothpaste. It's like hot, and when you're dealing with autism, that's even more accentuated because most of the time these kids are not verbal. There's, very little eye contact and very little socialization. So we have been making transdermal LDN for kids on the spectrum for quite some time. And we have a let's see, he's now 25, 26. Let's see, I got to do the math. Yeah, he's probably right in there. And he's still using transdermal because he's not very oral. He's very picky about anything that goes in his mouth. But for him, it works. And he actually applies his own. So he's absolutely brilliant. And he's been working for the last couple of years, probably the last 4 or 5 years. But he's brilliant. He is absolutely brilliant. But because his social skills really didn't develop until the last little bit, and of course we had nothing going on for 2 years, he kind of ebbs and flows with his social skills. But we did have a mom of a 3.5-year-old. I guess he's probably 5 or 6 now. So this was back in 2019. Mom came in and she was just bawling. And she came in to say thank you for transdermal LDN because her child looked at her and said, "Mommy, I love you." And that, that's what we live for, right? But when you have a child who doesn't look at you, doesn't really interact with you, but then turns around after being on a medication for several months and literally says, "Mommy, I love you." She says, that was huge. Totally made my existence of being a pharmacist. Completely did it. But we can also make water-soluble liquids if you'd prefer. They do have shorter expiration dates because of what the FDA and the USP allows us to do. And dosing with children does change a little bit because we have seen that they do metabolize a little bit faster. We saw this in this study, which I think is a pretty decent sized study of 66 patients. Literally saw a complete normalization of their menstrual cycle in, I think this was over about 6 months. What was really cool about this isn't a new study. This study's 30 years old. So why aren't we using this more and more, especially because we're seeing so many 20s and 30 somethings that are trying to get pregnant that are not being successful. And LDN is used throughout the pregnancy. So not just initially to help reduce inflammation so that we can see ovulation, we can see better implantation, healthier pregnancies, but also healthier deliveries, and then healthier babies. Because there may be an autoimmune component that just hasn't been noticed. There might be some PCOS, there might be some other things going on as well. I don't know. But what we did see in this study, and then also with Dr. Philip Boyle, is that it can very successfully be used even during pregnancy without harming the child. And this actually will play if I poke it. So Dr. Philip Boyle is one of my favorite people. He's just this normal dude. He's just so cool. And this was a presentation that he put up in 2019. It is on YouTube. I highly recommend anybody who's in women's healthcare, please go take a peek at this. You literally Google Dr. Phil Boyle, low-dose naltrexone, voila, there it is. And he may have a couple of them up there. The case studies that he has written up about the women that he has followed. Now, granted, he's in Ireland. They can do things a little bit differently than we can in the US, but that doesn't make the science any more or any less relative, right? It's still, they're still humans. Doesn't matter if you've got a beautiful Irish accent or not. We're still the same inside. So he has seen wonderful, beautiful, healthy babies and healthy mommies come out of using low-dose naltrexone. So it's thrilling. And I'm just going to bounce right over that.
Hello, my name is Dr. Phil Boyle.
See what I mean?
I am the director and founder of neofertility.com.
So he has this beautiful narrative with slides that go along with that. So what do we do at Makers to really allow for success? And like I said earlier, we set up the expectations very early. We let people know to kind of enhance how the prescriber is also introducing this medication, how it's going to work. Most people respond within 60 days, but please give us up to 6 months. And some people go, oh my gosh, really? Well, then I remind them, but how long have you been dealing with this? You know, many times it's decades. And how many providers have you seen? And how many medications have you tried? And how long did you try those? Well, give me 6 months, and then we're going to move on from there. We do provide a wide variety of handouts that go along with the medications. We make things as easy as possible. So as we're first starting out with low-dose naltrexone, we will start with a kit that has 2 strengths, a 0.5 and a 1.5 milligram capsule. They are both white. They're both little teeny capsules. So they're in 2 different colored bottles that then follow the schedule of the color-coded column so that it's easier to understand. So when we read from left to right on the graph, they understand how many capsules to take it out of what bottle during which week. And that's mainly because we're taking this medication generally at bedtime. And if you have to wash down 9 capsules right before bed, that's a lot of water, and nobody wants to be up going to the bathroom all night long. So we try to make it as easy as possible. And then we check in. We they can text us back. We provide a symptom chart. So it lists probably the top dozen to 15 symptoms that we're trying to get rid of. And they can rate that over time and how things progress. And then they can actually see it right then and there. We also are working with a company called Outcome MD to put together standardized questionnaires for patients to then go into a portal and actually see for themselves what is going on at baseline, and then whatever interval is scheduled for those questionnaires. And it's basically the same questionnaire over and over, but they can, on a graph, kind of like a speedometer, see where they're at and how they're improving over time. That information is also then given back to the prescriber so that the prescriber can see what's going on. And of course, this is a platform that all prescribers can use. It was actually developed by an orthopedic surgeon. because as people would come in and they'd say, oh, but how does this really work for other people? He wanted to be able to show exactly how that worked. So he developed this tool, and I think it's a phenomenal tool. So with our patient follow-up programs, we want to find their happy dose because it's very individualized, and we check up on a regular basis with that. Obviously, this picture was taken a little bit ago because she's still in her mask. We can also answer questions as they come up. Some people have side effects, such as a bloom. So if they have psoriasis, or if they have Lyme disease or another viral infection, Epstein-Barr, sometimes that underlying virus will actually come to the surface and bloom, so they might feel worse before they feel better. Dr. Sherman actually addressed that in last year's LDN conference, and that is kind of a phenomenon that happens some of the time, but not all of the time. It's not a guarantee. But we want them to be successful with their therapies, so we answer those questions early on so that we can reassure patients that this is a great program to be on. And then we always communicate back to the provider whenever we need to, and we always encourage communication back to the provider from the patient as well. As the patient owns their own care, we see better outcomes, right? We see less, I don't want to say trivial, but some phone calls going back to the provider's office could be handled differently. And sometimes answering questions can alleviate some office visits that maybe are not as significant. And we certainly do our best to keep people out of the ER and urgent care. Anytime we have better mental health, I mean, aren't we all the better for it? The community is always going to be enriched by that and better patient outcome. And obviously that's my hair a little bit ago too. So with LDN, as I said before, it's low risk, low side effect, low dose, and low cost. And we have well over 30 years of research as we continue to see benefit. We have a Facebook page, the LDN Pharmacist, as well as a website. You're welcome to go out and ask questions. You're welcome to go out and grab any documentation that you would like out of there. We're happy to help wherever we can. This is my personal cell. You're welcome to text me if you'd like information. You can also call the store. You can also go to pharmacy at makerscompounding.com. And you can also talk to Scarlett about getting specific top articles if you'd like those, or let me know and I'm happy to do that as well. And there's a question in the chat. Oh, there it is, pharmacy at makerscompounding.com. Thanks, Scarlett. Any questions that I can answer that we have not addressed? Did I skip over any burning questions that anybody might have? All righty. Well, I thank you all very much for attending tonight. I hope this isn't our last conversation. In November, we will be talking about hormones, so please join us in there. And again, you can register by texting webinar to our phone number. You can also register on our website. And I thank you all for joining us. I hope you all have a lovely evening. Thanks, everybody. Take care.